Okay, so in this lecture we talked about infection, and basically an infection is um, damage to cells, tissues, or organs due to an invading pathogen. Okay, and the three lines of defense have been breached in some way. That's the only way an infection can really establish itself, is if they have evaded our own defenses. Of course, infection's a very serious public health issue. A lot of this is because of globalization, so basically people travel more and things are spread around. Also, antibiotic resistance, of course, is a huge issue that I've talked about a lot and probably will continue to talk about for the rest of my life. Okay, so pathogens, these are just, microbes that cause disease. So these are things, of course, like bacteria and viruses, but also fungi, protozoa, and helminths, which are basically worms. And they can cause disease by directly destructing our tissues. That can just be from growing in a certain area, interfering with our metabolism. Viruses in particular are very good at that, and also producing toxins. So, certain bacteria produce toxins that can harm our tissues. Now, pathogenicity, that's just the ability to cause disease, the ability for a pathogen to cause disease. And things that affect pathogenicity are things like virulence. Virulence is basically how pathogenic a microbe is, so how potent a microbe is. Toxigenicity, this is the ability for a pathogen to produce toxins like bacteria. Antigenicity, this is basically how well our immune system recognizes a particular pathogen. Antigenic variability, this is the ability for a pathogen to kind of change some of its surface antigens. So, if this is, so if we have a pathogen here that has this antigen on its surface, antigenic variability, something changes in the genetic material that allows this bacteria to now produce, an antigen that looks something like that. Okay, that's antigenic variability. And that's just a few examples. There are others that affect pathogenicity, but those are the ones you should be familiar with. Okay, we quickly reviewed some of those portions of the cell wall, and we talked about the cell wall and the other components of the bacterial cell. I'm not going to go back into all of those. We took a whole course that basically explored those things. So again, just some of these organisms that are that tend to infect certain areas of the body. Then we talked about the chain of infection, and these are all the links in the chain of infection. All of these things are necessary in order for an infection to kind of settle in. So first off, you need an infectious agent. Okay, you need something to cause the infection. All right, and these infectious agents come from reservoirs. Reservoirs are basically the natural environment that you would find the particular agent. Now, it's different than a source. The source is, where you actually get the microbe from. We need a portal of entry, so there needs to be a way for the microbe to get into our system. We need a portal of exit. Microbes have to be spread from person to person in order to continue to live. So that's also important. And typically the portal of exit is the same as the portal of entry. Not always, but typically. You need a susceptible host. The person has to, have the environment for microbes to grow and cause infection. And then, of course, a means of transmission. We talked about all of those in micro. But basically, those are all the things that are necessary for infection not only to settle in one person, but also to spread to other people. And, we talked about the ways in which we can kind of break these chains to stop this chain of infection. Okay, so the stages of infection, after you're exposed to a pathogen and it starts to grow, typically infection's going to follow these 4 stages. So the first one's the incubation period. This is where you don't have any signs or symptoms. The pathogens are starting to grow and they're getting ready to spread. Prodrome, this is where you have kind of mild symptoms. They're not specific for anything. So, I always give the example of the common cold. You'll get like a sore throat. Prodrome is not present in every disease, but in some diseases it certainly is. Acute illness, this is when you have the most severe symptoms. And then convalescence, this is when you are starting to recover. This is when you're starting to return to a pre-disease state. And again, depending on the disease, you can be infectious in any of these stages. Okay, this is just showing basically these phases of infection and what's going on with the immune system. It's just pretty basic. Don't worry too much about this. Just know these phases and what characterizes them. So complications of infection, the average healthy person is able to resist infection, or at least get rid of infection. However, there are complications. So septicemia, this is when microbes get into the blood. So, if bacteria get into the blood, it's bacteremia. If viruses get in the blood, that's viremia. That certainly can be a problem because that could lead to something like septic shock, which is a very vast systemic state of vascular collapse and drop in blood pressure. And this is due to, severe disseminated infection. Gram-negative bacteria are really famous for this because they have that lipid A endotoxin in their cell wall, or actually their outer membrane. So yeah, that's septic shock. Chronic infection, this occurs in some pathogens, so things like hepatitis C virus causes chronic infection. Tuberculosis causes a chronic infection. There's a number of examples. So these are all complications of infection. But again, in a normal, healthy person, we are able to fight off most pathogens. So this is just showing, gram-negative bacteria. When they start to multiply or when they die in the body, they release their LPS, their lipopolysaccharide, which has that lipid A endotoxin, and that's going to stimulate this massive inflammatory response, and that results in, fluid leaving the bloodstream. That's the vascular collapse, low blood pressure, septic shock. So manifestations of infection, basically, they're the same as the manifestations of inflammation because infections induce the inflammatory response. So local manifestations, things like redness, heat, pain, and swelling, but also lymphadenitis, so inflammation of lymph nodes, pus, especially in bacterial infections, splenomegaly, so enlargement of the spleen. That's just a couple of examples. And then systemic manifestations, things like fever and malaise and weakness, and if you're talking about blood work, things like leukocytosis or leukopenia, all of those are systemic. So diagnosis of infection, blood work, of course, the CBC and a white blood cell count differential, really, really important. I mean, it's not looked at enough, but the differential is very important because it can tell you a lot of things. But in general, leukocytosis, that's going to typically indicate bacterial infections, and then leukopenia, which is a low number of white blood cells, that would be more indicative of viral infections. Again, that's not always the case, and these can certainly be the result of other diseases like cancer, but we're talking about infection strictly right now. Another way to diagnose, is antibody titers, which is just a level of a particular antibody, and that just says that you've been exposed to a pathogen or an antigen, but that doesn't say that you have an active infection. And then of course cultures and sensitivities. So you're going to want to culture things like bacteria and fungi, and then test their sensitivities for different antimicrobials. So treatment, again, like I said, we will clear most of the infections that we come down with, but we do have some drugs, especially antibiotics, which are going to be effective against bacteria, and they typically are going to target things like the cell wall and the ribosomes because they're different than our own cells. So the ribosomes and the cell wall are perfect targets. Antivirals, they don't work really well. There's just a handful of them that are used regularly, but they're typically in the class of drugs known as nucleoside analogs, and they are just going to interfere with the replication of the genomic material of the virus. And then antifungals, a lot of them will either target ergosterol, which is a part of the membrane of the fungus, or the production of ergosterol. Again, this is just a sterol that's in the cell membrane of fungi. It's different than what we have, so it makes a decent target, but they're still not great. Okay, then we started talking about the diseases, starting with influenza. So influenza A, B, and C, specifically A. Basically, this is spread by respiratory droplets, can be direct or indirect, and these viruses are going to enter epithelial cells. They're going to replicate inside the epithelial cells. They are going to eventually kill the epithelial cells. And the problem with that is these epithelial cells are ciliated, and the cilia is important for moving mucus up and out of the respiratory tract. So when you lose that, you can have settling of mucus down deeper in the lungs, and that can, bring bacteria and allow bacteria to kind of set up shop, and that can result in a secondary bacterial pneumonia. So this rarely progresses to viremia. That's just kind of a fun fact. Clinical manifestations. So again, like a lot of viral infections, especially of the respiratory tract, a lot of it's just due to our immune response and not the actual virus. But, clinical manifestations, of course, relatively rapid onset. It's usually pretty quick. Cough, sore throat, fever, body aches, fatigue, nasal congestion, nasal dripping, all of that stuff. So diagnosis based on history and exam, and then the rapid viral assays, which have a 20 to 30% error rate both ways, so that's something to keep in mind. And then treatment, symptomatic care. There are antivirals out there like Tamiflu, which, if they're used within the first 48 hours of the onset of symptoms, might be effective. This is just showing the influenza virus particle. So it's an enveloped virus. It has these spikes called H and N. H is hemagglutinin, N is neuraminidase, and then you have this. They have an interesting RNA genome inside of the viral particle. And of course, hand washing, vaccination, not touching your eyes, nose, and mouth. Those are good ways to prevent influenza, especially in our epidemic right now. So hepatitis, viral hepatitis is inflammation of the liver. And, there are A, B, C, D, and E subtypes. Types A and E are transmitted by the fecal-oral route. And then B, C, and D are through contaminated bodily fluids. D is special. Hepatitis D is special because it requires a co-infection with B, hepatitis B, and I talked about that in class. So A and E, the ones that are fecal-oral, typically cause acute infections that are relatively self-limiting. HBV can have a chronic phase, but also an acute phase, and hepatitis C is typically chronic. Basically, these viruses invade the liver. They kill hepatocytes. This could be in just a portion of the liver or even, throughout the entire liver. And what happens is, especially in the chronic types, is as these cells die, they're replaced with scar tissue, and this, of course, can obstruct blood flow. So clinical manifestations of acute hepatitis. So acute hepatitis is typically going to have three phases. The prodrome, which is characterized by things like fever and loss of appetite, fatigue, malaise, headache, things like that. Then it's going to have the icterus phase, which is the jaundice phase. This is where you'll see jaundice, you'll see the clay-colored stools, dark urine, and again, that's all associated with the bilirubin. And, 2 weeks after exposure. And then you'll have the recovery phase. So jaundice goes away, you start to feel better. This is basically convalescence. And most people have some level of hepatomegaly for 1 to 4 weeks afterwards. So, of course, this is jaundice of the sclera of the eye. So clinical manifestations of chronic hepatitis, this is impaired liver function due to a viral infection for more than 6 months. So manifestations are similar to acute hepatitis, but they tend to be less severe and longer lasting. However, things like cirrhosis, this is end-stage liver disease, this can occur and does occur, especially with things like hepatitis C. So we know what cirrhosis is. We talked about cirrhosis. I'm not going to hash out all of those details again. But again, that can definitely be a result of chronic hepatitis. So diagnosis and treatment of hepatitis, H&P, anti-hepatitis antibody titers, to show exposure. Elevated bilirubin, for sure. Prolonged clotting time, again, prolonged clotting time because the liver produces clotting factors. If it's not functioning normally, it's not producing those clotting factors. And then treatment, for A and B, there are vaccines, so that's good. Prevention, also washing fruits and vegetables, and being aware of where your food's coming from, and also symptomatic care. Antivirals, especially for hepatitis C, there is a drug out called Harvoni, which targets one genotype of hepatitis C, genotype 1, which is the most common genotype. Okay, then we talked about tuberculosis, which is a pulmonary infection spread by aerosol droplets. This is the most prevalent and deadly infectious disease in the world. And I've said it before, I'll say it again. 33% of the world's population is colonized with Mycobacterium tuberculosis. It's around. Now, of course, 1/3 of the world's population doesn't have active TB, but it's out there. So basically, upon initial infection, you have these granulomas that form. They're trying to wall off the bacteria, but they can't quite get rid of it. And as these granulomas accumulate, you get what's known as a Ghon's complex or a Ghon's focus. And again, this is associated with the primary infection. Now, secondary infection or reactivation. So say you have a primary infection and then it kind of goes latent. You can have reactivation of that TB. Or you can have, you may have cleared it the first time and then you have a secondary infection, you get infected again. This can cause a much more severe, much more disseminated disease, and that's, very deadly. So here you can see we have this healed lesion. This is a Ghon's complex. This is just this ball of granulomas, and again, this is associated with the primary tuberculosis, primary infection. Okay, so this is kind of showing primary and secondary tuberculosis. So you, again, aerosol droplet route, they kind of set up shop in the lungs. So if this is the first time you are exposed or the first time you inhale these bacteria, you'll have a cell-mediated hypersensitivity response, okay, like a type 4 hypersensitivity, and that's going to eventually result in activation of macrophages, which form the granulomas, and that, of course, is going to make the Ghon's complex, and then this can heal itself. However, it can reactivate, and this can give you that disseminated TB, which is deadly. Sometimes this is known as miliary tuberculosis, if you've ever heard that. You don't need to know that for the exam or anything, but just if you've heard that term or that phrase, it just means disseminated tuberculosis. And again, disseminated tuberculosis can also occur with a reinfection. So clinical manifestations, most people are asymptomatic, but if somebody has active disease, things like night sweats, swollen lymph nodes, weight loss, fatigue, fever, and cough, and this cough is typically productive with bloody sputum, which is hemoptysis. So diagnosis, the TB skin test, again, this only shows exposure, doesn't indicate active infection. A chest x-ray can show active infection. Sputum culture and sputum nucleic acid identification, those are good because they're not affected by the BCG vaccine, which is a vaccine that you may get if you travel to other countries. But if you get that vaccine, you will have a positive TB skin test. But the nucleic acid identification or amplification, that's a really good test because it's much more rapid than a culture. And it's pretty sensitive and pretty specific, so that's a good test. So treatment, typically long-term use. It's a regimen of these 4 antibiotics, and this can be from 6 to 12, typically more than 12 months, typically no less than 12 months. So, the key here, though, is directly observed therapy, which basically means somebody needs to see the patient take their dose every time they take it, because if they don't, 1, they're not going to get better, and 2, they're going to have a problem with resistance, and you don't want to have antibiotic-resistant TB. All right, then we talked about bacterial meningitis. So inflammation of the meninges, which are the 3 layers surrounding the brain and spinal cord. So inflammation of the meninges due to bacteria, most often Streptococcus pneumoniae, but also Neisseria meningitidis, which hopefully you change this in class, but if not, if you're watching this video, please change this now. So Neisseria meningitidis, not Neisseria gonorrhoeae, that causes gonorrhea. So pathophysiology, aerosol droplets. A lot of people are actually colonized in the nasopharynx with these bacteria, both of them, but a lot of times they don't cause any problems. However, they can kind of reach the meninges, and they have tropism for the meninges, which means they select for that tissue. That's what they like to bind to. And the problem here is you have an inflammatory response, and this inflammatory response is occurring within the capacity of the cranium or in the vertebral column, and that's bad because it's a tight space. So you have edema, which is associated with the inflammatory response, and as that edema increases, you obstruct the flow of CSF, and that's going to increase intracranial pressure, and that's going to decrease blood flow to the brain and oxygenation of the brain. So here we have the meninges. So right on the brain and the spinal cord, you have the pia mater, and then you have the arachnoid mater, and then you have the dura mater, which has a couple layers, and the dura mater is, a tough, thick meninx. Meninx is the singular form of meninges. And also with meningitis, it can affect one or all of these. Okay, so just keep that in mind. Clinical manifestations, there are a couple of good, kind of indicators of meningitis. Rapid onset of fever, severe headache, photophobia, nuchal rigidity, which is the stiff neck, also nausea, vomiting, changes in mental status, all of those. Diagnosis, history and exam, CSF analysis, so you always do a spinal tap if you suggest meningitis, and you'll do a culture. You do a culture of blood to see if there's any sepsis, and then positive Kernig's or Brudzinski sign, which I'll show in the next couple slides. So treatment, IV antibiotic therapy, typically starts out very broad spectrum, and then you kind of narrow that down as you get your cultures back, and fluids, corticosteroids to reduce inflammation of the brain space. Okay, so this is Brudzinski sign. Basically, you have the patient lying supine. You will flex at the neck, and they will have a reaction where they flex at the hip and then flex at the knee, and they'll have pain, of course. And Kernig's sign, again, the patient's lying supine. When you flex the thigh at the hip at a 90-degree angle and then try to extend the leg, you have pain and tightness in the hamstrings, more than what would be expected normally. Okay, then we talked about tinea, which these are fungal infections that affect the skin. And you can get these through direct contact or contact with contaminated surfaces. Now, there are a number of different species of fungi that cause these tinea infections, but we just collectively call them as the dermatophytes. Dermatophytes cause tinea infections. So that's just a general term for the type of fungi that cause these infections. So basically, these dermatophytes will attach to skin, and they will grow. They don't do a whole lot of damage themselves, but the immune response does quite a bit of damage to the skin, and it causes thickening of these keratinized cells in the epidermis. So clinical manifestations depends on the site. So there are different types of tinea, based on where they occur. So tinea corporis, this is just body tinea, and this is ringworm. Tinea capitis, this is on the scalp, so you'll have hair loss, hair breakage, all of that stuff. Tinea pedis affects the feet and the toes. This is athlete's foot. Tinea cruris, this affects the groin. This is called jock itch. And then tinea unguium, this affects toenails. It's more commonly called onychomycosis, though. So diagnosis and treatment, prevention's the best. Don't touch things that look gross. Don't walk around barefoot and, at the Y or anything like that. And as far as treatment, often a combination of oral or topical antifungals. And then finally, we talked about malaria, which is a protozoal infection. This is caused by Plasmodium species. So there are a couple that cause malaria, and these are mosquito-borne, so they're transmitted by mosquito. We don't have this in the United States, but it is extremely deadly on the world scale, so it causes more than 1 million deaths a year. As far as the pathophysiology, incubation period is about a month, and there's a very complex life cycle which you don't need to know. But just know that it's complex and there are different phases. They'll spend time inside red blood cells. They'll spend time in the liver. It's very complex. But the clinical manifestation is very flu-like. So things like fever. Fever is actually typically pretty high, but also headache, fever, chills, body aches, cough, all of that stuff. Diagnosis. History is really important here. So if you have these clinical manifestations and you recently traveled to an area where malaria is endemic, like portions of Africa, that's an important finding. But also liver function tests, like I said, malaria spends some time in the liver, or Plasmodium spends some time in the liver, and then peripheral blood smears, which will actually show red blood cells that are infected with the parasite. So treatment, anti-malarial drugs like the quinolines and the sulfa drugs and the antifolates, all of those are used for malaria. Prevention's good, insect repellents, especially ones that contain DEET, D-E-E-T, mosquito nets to keep mosquitoes away, and of course wearing long sleeve clothing. If they can't get to the skin, you can't get malaria. So this is just showing a peripheral blood smear with these Plasmodium protozoa inside the red blood cells. You can also see how abnormal these red blood cells are once they're infected. So this is a nice normal red blood cell, and you can see how the morphology of these cells has changed.